Hi, welcome to ComplyPlus Presents. And today we're going to be focusing on why domiciliary care providers are failing CQC inspections and hopefully offer a little bit of insight in how they can fix those problems. So, if you're a domiciliary care provider, this should be very useful for you. I'm joined by Dr. Richard Dune again today. How are you doing, Richard?
I'm good. I'm good. It's good to be back. And obviously, some of these lessons from today can be used in any setting. Although we are focusing primarily on domiciliary care providers, these elements can also affect other providers.
Definitely.
So, because CQC single assessment framework is applied in a similar way across different settings, obviously customized to each setting.
Yeah. No, it's a very good point.
Yeah.
The reason, we've chose to look at domiciliary care today is based on some of the latest data from CQC, primarily, where there seems to be a growing number and a theme almost of poor ratings in that sector. We feel, as someone who's operating in this space to support with training, compliance, that it made sense this week to discuss this topic. So, Richard, from your side, what do you, as a quick introduction, what do you make of this data, and why were you so keen to do a podcast on this theme today?
Yeah, when you look at domiciliary care companies registered with the Care Quality Commission to provide regulated services, there are over 15,000. So, as a group actually of providers, they are the largest group of providers. And also, when you then look at organizations that have been rated inadequate by the Care Quality Commission, they also form the largest group of organizations rated inadequate. So when organizations are rated inadequate, they're basically failing in every sense. And unless they are put in special measures where they are radically transformed, they are not fit to provide services, regulated services. And as you see with some of the examples we're going to use, we're using real data and using real examples, although we are anonymizing them. We've also, over the years, dealt with companies that were inadequate, and some of them we helped them to come back from being in a rated inadequate to good and even outstanding. We had a few outstanding over the years. But also some organizations, there was just nothing to save. Some of them ended up being shut down because commissioners feel that they are unsafe. And that's what we need to think about here as well, to say when organizations are failing to meet the basic standards, some of them may need improvement. So with a bit of improvement, then they will go back to good. But some actually, things are so bad,
they're beyond
repair almost. Yeah. But in many instances, a lot of it is to do with just poor governance, poor leadership in general. But sometimes it's unintentional as well. Maybe they failed to understand the guidelines. Maybe the people have got into the sector without fully appreciating what it means to provide regulated services. And that's a problem as well in itself, to say, I've written about this in articles and even on LinkedIn, to say people used to call the care sector as safe as bricks. So in the 80s, early 2000s, a lot of people were investing in the sector, which is good because obviously you need investment in the sector. But you need to appreciate that providing regulated services comes with responsibilities. And it's not the kind of business that you open, then you step away
and hope it starts working
and
and
hope it
making
starts
money.
working.
Yeah.
We've seen some companies where the owners don't even live in this country. Not that obviously if you put a management team and you've
place,
got good
then,
structures, then that's good. But actually, quite a consistent theme is that quite often when the owners of the business are not even there, they're not involved in the day-to-day, then it, in quite a few cases we've seen things go the other way around because they don't quite appreciate what it takes to keep an organization that was rated good to remain good.
Yeah.
Right. It's quite easy to then drop from good.
It's quite easy to go down the ladder, isn't it?
Exactly.
Compared to going the other way, or even maintaining standards.
Yeah. And for me, the way I look at this is we should also provide solutions. Because our business obviously is about solutions, but never mind the business. We shouldn't just talk about how bad things are. We've got the tabloids doing that already. Every day there's a bad news story about the NHS or care homes, the state of care, and things like that. I'm all about deep diving to understand why organizations have been rated inadequate. What can we learn so that we can improve things? And also the organizations that are good realize actually that it takes a slight change and things can go the other way around.
Yeah. That makes sense. So we wrote down, when we were preparing for this episode, we put down some common themes really that are maybe causing domiciliary care providers to get inadequate ratings or auditors finding areas of improvement. And one of those was either missed or rushed visits when people are entering the service users' homes. Quite a lot of visits from the data we've seen were completed in just 7 to 10 minutes on average, when it should be 30.
Half an hour, yeah.
Double up calls being completed by single carers going into the service users' homes. And also, probably rather more starkingly than some of the other points there, Regulation 12 being breached, where service users are not receiving adequate care, the necessary support, or even the correct medications.
Yeah.
So 3 quite shocking areas to go into. But like you say, rather than dwelling on that side of it, what are the fixes? How can providers improve this and put good systems in place?
Yeah. I mean, these are shocking numbers, but obviously we have to look at solutions here. When you look at most of the care companies, almost all the care companies we've encountered, they're using the electronic home monitoring systems, so the ECMs. But it's very passive. The old adage, well, we're going to innovate, so we'll get some tech to do this. But then we bring the tech and we tick the box to say we've got the software, but actually we passively use it.
Yeah.
Because even with a simple audit, actually, when you are auditing a care business, for example, for governance and compliance purposes, you can look into these systems to see how they are being used. And that's where you see actually a lot of the errors. And in a lot of cases, they don't even understand the data that is sitting on the system. So an auditor or a CQC inspector can easily see, oh, can you show me, oh, you've got an electronic home monitoring system? Yes. Okay, then they look at it and the data is sitting there. Because these systems use GPS.
Yes.
So if I'm delivering care in the client's home, it will say that I am in the client's home. GPS
it's a tracker,
so
it shows you where you are,
But actually, in quite a few instances, like here, where in central Coventry, the person is pinging, say, 5 kilometers away, 5 miles away, and they're saying that they're delivering care. So they fill in the details from a different location altogether to where the care is supposed to be delivered.
So that would hint at, obviously, like you say, the people auditing or monitoring that system are obviously not bothering.
Non-existent.
They're just assuming the carers
It's passive.
Yeah.
And it's not only in small companies. I used to work in the NHS. It was the same with some systems where you're collecting a lot of data. Because I was in research, I was interested in the data, and I always wanted to see what the data are telling us. But actually, you realize it's passive. We're using it maybe it's got 20 functions. We're only using 1, perhaps. So some of it is unintentional. But obviously, when people are signing to say they did 30-minute call when they've done 10 minutes, that's fraud as well. And think about, but also it's shortchanging the customer,
Yeah, the person who needs the care.
The person who needs the care. Yeah. So that's really crucial. And you look at travel times. We know that the sector has had a lot of issues, and even the providers themselves are right now really struggling. And the latest reports are showing that the state actually, is almost complicit in some of the issues that are happening in the sector, where there's an awareness of where the problems are, and also the fact that companies are underpaid and things like that. But it doesn't justify fraud. It doesn't justify sending 1 carer when you're charging for 2. I know there are shortages, yes, but these issues need to be addressed. And if it means that people go back to the commissioners to address how they're being paid, or to reevaluate the care packages, then so be it. right? So, but otherwise, it's a big issue, and there are many things that people can do. The most important part is the audits and visit logs. So if you're a care manager, you're a registered manager, that's part of your job, part of the governance, Regulation 17, good governance, is to check that these systems are working properly,
Yeah.
to check that the systems are fit for purpose, to check that your carers are actually completing the visit logs properly. It's part of the governance framework.
Yeah.
And it goes back to audits. And that's one of the things that we are doing to teach people how to carry out audits, really basic audits. You don't have to be a specialist to do that. There are things that you can do. We have built checklists that people can use, and carers also can give feedback. You can also ask for feedback from the service users and their loved ones to fill in the feedback. So, yeah, a lot of issues, but they are solved by good management,
Yeah.
good software systems, and using them proactively rather than passively.
Yeah. And
Yeah.
like you say, good standard operating procedures are needed. And even internal audits, like you were saying, a lot of people just assume audits are by external people like CQC or whoever. Like you say, actually having internal audit systems, I
It's
think,
crucial.
can stop some of these things.
It's crucial.
early.
And this is some of the things as well when you look at the health and social care level 5. It's very theoretical
Yeah.
in many ways. And also it depends on the provider. The qualification, yes, it's like a degree. If you get a degree, can you actually go and use the tools and apply the tools? And for me, really, that's my background is in research and audits and governance. And I'm always keen to try to get people to see actually that they can do it themselves. Because even in the higher external auditors or consultants, we were talking to some colleagues about this to say a lot of the consultants actually, they don't know what they're doing. They don't have the occupational experience. So you're hiring people and paying them a lot of money for something that you probably do better yourself. If you take some time out to learn how to do it, if you take some time out to audit your own systems. And I think that's the challenge ahead for us, in the sector, to sort of say educating people, not just to get certificates, but educating and training them so that they can go and use these tools in their own businesses so that they have a better understanding of what's going on in their businesses and deliver better care.
Okay, yeah.
Yeah.
So the next thing we wanted to look at was medication mismanagement. So some of the failings, again, based on the data and research we've been doing, is things like incomplete or unsigned medication administration records, no protocols for PRN medication, unsafe use of topical creams, insulin, or warfarin, and again, a breach of Regulation 12, where there's unsafe handling and administration of medicines.
Yeah.
So 4 quite worrying things in the space of medication mismanagement. So again, what are some of the things providers can do to fix this and stay on top of this issue, which, like you say, it's quite serious when people are not getting the right medication.
Yeah. Medications, that's a really serious issue, and not just in domiciliary care companies. It's across the board. I worked for many years in frontline nursing, in emergency departments, in cardiology, outpatient settings. And medications are crucial because then that can make a difference between somebody surviving or dying. That can make a difference between someone managing symptoms, things like that. So the MAR charts, which is the medication administration records, traditionally they were paper-based systems where medications are prescribed. So when they are prescribed, it tells you the dose, it tells you the way the person is going to take the medication, it tells you what times, how often. There are a lot of things to consider. And when you think about it, actually, nurses go to university for 3 years to study. They do theory, they do practicals, they go to placements, and they learn about medicines. So they do pharmacology module, and even after nurses qualify, 3 years training, lots of placements, lots of exams, they would need to work for at least 3 to 6 months under supervision before they can start to administer medicines by themselves.
Yeah.
But we are getting care companies sometimes who are bringing people that are completely new to the sector. They'll go and do an online course for 30 minutes to an hour, and they're ready to go with very minimal supervision. That should scare everyone.
Yeah. definitely.
Yeah, it's dangerous. So we need to start by looking at the training and also the systems that we're using, the supervision. So induction training, the statutory and mandatory training should include medication management, then supervision as well. When people are doing the care certificate, during those 12 weeks that they're doing the care certificate, if they're new or don't have qualifications, then they're signed off.
Yeah, definitely.
Yeah, because medicines, you need to know what the medicine is for. You need to know the contraindications. You need to know about reactions, adverse reactions, and be able to deal with those adverse reactions. If somebody's got an anaphylactic attack, an anaphylactic shock, following taking new medications, what do you do? So even the emergency first aid or resuscitation skills. So the problem for me is that when people do training, they're doing it as a separate thing from the policies. Because of some of the policies that we have looked at when we did audits, they're so poorly written. They don't align actually with the regulations. And you can tell that they've just taken a template somewhere and brought it here, put their logo and name. It doesn't actually match what they're doing in practice.
In practice.
Yeah. So that's the starting point. So we need to fix the training. We need to fix the policies so that they align with the training.
Yeah.
We need to check for competencies and sign people off. But also managers should do regular audits. You see, this is a recurring theme, and spot checks. Because actually, if you've got, say, 20 clients, you can rotate how often you do your spot checks and audits as part of your care planning and record keeping. Also, that needs to be embedded into what we're talking about here. Then there are some high risk medications. For example, medications that you mentioned, like warfarin, is a blood thinner. So if you get an inappropriate dose, say a high dose, you can bleed to death. If the dose is lower than what it should be, then you can get clots and potentially die from a pulmonary embolism, so a clot on the lungs or a clot in the brain, things like that. So these are dangerous medications when you think about it. Even diabetes, even epilepsy. The window between getting it right and getting it wrong is so small, right? So for me, that's really crucial to train people on those medications, any medications, but particularly on those high-risk medications. Warfarin, there's a number that you need to check. And then that number determines what dose you have. So the prescriber's instructions have to be clear. But obviously, if somebody is bleeding or there are signs that somebody could be bleeding, then that medication should be stopped and you check before you administer it. Again, I spent 3 years training as a nurse. Then I went to do postgraduate training, research training, and all that. But you get a carer doing this.
With limited supervision or oversight,
It's scary.
So
So
the chances of things going wrong are going to be a lot higher.
Exactly. Then PRN use is medication that you need to take as and when. So this medication is prescribed. Maybe when I'm in pain, I can take this medication, but it needs to be recorded properly. It needs to be used appropriately. You need to stick to the doses. You need to check what else I'm taking because there could be contraindications. And sometimes people are prescribed these medications to take as and when, then they are not reviewed. Then they get put on another medication that is doing exactly the same. Then you get double dosing, which is just as dangerous as underdosing. So it's overdosing, right? Then topical applications, you talked about some creams. Some creams actually, they are quite inflammable. So there's a risk of fire, somebody burning, and even the carer, right? So all these checklists, risk assessments must be done. And it's up to the managers and supervisors to put these systems in place and then audit these elements. So digital, most companies have gone digital now, so these systems are digital. So one thing to think about is when we take a technology into a care setting, how are we going to monitor its use? How are we going to audit? That should be part of the procurement decision, not an afterthought to say, whoa, we've got this system 6 months down the line, you have no idea where your data is sitting. You have no idea how to audit that data. And again, digital literacy, I'm realizing more and more, is crucial in the health and social care sector, not just the care sector, not just domiciliary care companies. This applies across all the records, across the board, rather. Because if you have medicines management systems that are digital and you don't know how to audit them, then how are you going to keep people safe? how are you going to know that your staff are staying within the regulations? Because Regulation 12 is very clear. It's about keeping people safe by giving them safe care and treatment.
Yeah.
And it's one of the most commonly breached regulations across the board.
Well, we're going to see it as a theme
Yeah.
as we go through some of the other points.
Yeah.
The next one I wanted to talk about was risk assessment failures. So some of the failures that were highlighted, again, from our research team were no assessments for choking, hoist use, catheter care, epilepsy, or diabetes. And again, that Regulation 12, inadequate risk management compromises safety. So again, it's a Regulation 12 breach. So they were the two most common that we sort of discovered when doing this. So again, what are things people can put in place outside of maybe the obvious things here? What are some of the things people can start doing to improve this?
So it goes back again to the basics. When you look at Regulation 12, we can start with basic health and safety. So health and safety training, I always joke, when I talk to people, ask them what they think about health and safety. They find it boring.
Yeah.
They find it's over the top. They find it unnecessary.
Yeah.
Oh, what can you possibly teach me about health and safety that I don't already know? But actually, it starts with the health and safety policy.
Yeah.
Risk assessment processes.
Yeah.
Right? Somebody's at risk of falls. How are you going to manage those risks? Are they clearly documented in the care plans? So it goes back to basic care planning and record keeping, taking adequate history, then thinking about the risks. Like in domiciliary care, most of the people that are being looked after or supported are older people that are dependent on carers coming in and managing risks for them, identifying the hazards and managing risks for them, right? So whether you're talking about falls, you're talking about nutrition, mobility, infection prevention and control, all these things need to be identified. So comprehensive, person-centered care plans. So care planning, very basic, when you look at the activities of daily living for each individual, what is it that they can do independently? You want to promote as much independence as possible. Where do they need support? So even the previous point where you were talking about one carer going in instead of two, there's a reason why you need two carers, because maybe the risk assessment suggests that you need two people to move this person from bed to the commode or vice versa.
Yeah.
You need two people to manage a hoist.
Well, like you say, that decision is made based on the risk assessment, isn't
Exactly.
it? Yeah.
So we're going back to the basics again. And once you do a risk assessment, it doesn't stay permanent.
No. Factors change.
Things change. So it's a dynamic document. Risk assessments in care settings are dynamic. Somebody can have a fall. Then when I come back to my shift the next morning, everything has changed. Maybe they've had a stroke or whatever. Maybe they're in pain.
Yeah.
Right? So as and when significant events happen, you update them. But care managers and supervisors should also regularly audit and update care plans. But don't update care plans without involving the carers themselves. Because in some organizations that we work with or have supported over the years, you find that care plans are handled by senior staff. Junior staff are just doing the work. But actually involve them so that they learn, so they understand and can connect things. You can't update care plans without involving the people that are doing the work itself.
Yeah. It's mismatched.
It's mismatched, yeah. Then staff training in health and safety, risk assessments, recognizing actually, so hazard identification, risk assessments, and then also how to escalate. What do you need to do in emergency settings, but also where it allows, how do you escalate so that maybe somebody senior can do something about it. Then one other issue as well is around incident reporting. And we've had recent conversations with a few key clients. I was shocked actually with some of those clients to say they don't have robust incident and accident reporting systems. So even if you're using a paper-based system, again, do people know how to report
it? Yeah.
near misses, incidents, accidents? Do they know which form to fill in, where you have 2, 3, 4 forms? And even where you have a digital form, do people feel confident in filling it in and putting all the necessary information? Then the person receiving that information, whether it's a dedicated health and safety manager or care manager, whatever their title is, the person responsible, do they then go and look at the evidence, maybe talk to people, or rather, do they look at the bit of paper and then just update the care plan without talking to anyone? It has to be a two-way system and even involve the people receiving care themselves.
Yeah.
Right. So for me, again, we are rushing to get digital systems without having the fundamental understanding of how to manage risk in care settings. And that is a big challenge.
Yeah. That's probably one of the key takeaways there,
Yeah.
isn't it? Because people are rushing for tech. But
Yeah.
yeah, tech's only as good as how you use it. One of the other failures we wanted to look at were safeguarding failures. So, again, another theme, incidents not reported to CQC or the relevant safeguarding teams, staff unaware of safeguarding policies. We've touched on that and some of the other failings we've highlighted today. And this time, Regulation 13 breach. So, a failure to protect people from abuse and neglect, which is obviously very, very serious. And there's been a lot of sort of famous cases in the news just this year, unfortunately. So again, where do we go to try and fix this?
We go back to the basics again. Hiring the right people, checking that actually these people, they're safe to
Yeah,
work with vulnerable people.
their own backgrounds,
Their
as
own
well,
backgrounds. Yeah. And, Regulation 13 is very clear around ensuring that people are protected from abuse and neglect. We saw what happened with Mid Staffordshire NHS Trust scandal and others, and even the resultant Care Act, the resultant need for organizations to improve their induction training, including the care certificate. So it goes to induction training and onboarding people, statutory and mandatory training, including safeguarding, and it needs to be customized to your organization. You can't just go for generic safeguarding training and think it's enough.
I think that's the only thing. But that's the thing with generic training. It's good for the theory side.
Yes.
But like you say, how do you apply it in your role and to the policies that you're supposed to follow?
That's where induction comes in.
Yeah,
Yeah. So
exactly.
people
And
can do
supervision.
generic e-learning, for example. Then they come into the organizational induction where you're now localizing what you have learned. Because the principles of safeguarding are the same. Whether you're a doctor, you're a nurse, you're a care worker, the basic principles are the same. But how do you apply them based on your role and responsibilities? Right. So that induction training, statutory mandatory training, part of the care certificate for care workers, and the refresher training as well, but also part of the supervision. When people are now up and running, checking with them. Because sometimes all you need to do as a care manager is to do a lunch and learn every shift. Who's on the shift as part of the handover? You can take that opportunity to actually, train people.
Train people, yeah.
Yeah, but obviously formal training is crucial. Then clearly, people also need to know rather who is responsible for safeguarding in the organization and how do they escalate issues. So any safeguarding concerns, how do they report them within the organization? Some organizations have very good systems until it's out of hours or weekend or bank holiday.
Or bank holiday, yeah.
Right.
The classic.
Yeah, or the person who's normally doing it is not there, but there's no delegation when they're away.
There's no cover or
There's no cover. Who's going to be dealing with
contingency,
safeguarding issues, right? So some of these actually they have to be reported straight away. CQC have to know. You have to send a notification. Commissioners. So depending on the contracts that they have, it's about having good systems in place and then linking those systems with your policies and procedures, but also safeguarding audits. Some organizations do them monthly. But obviously, when there's an incident, you then have to do it
immediately. Right?
immediately,
Yeah.
so that actually you can learn very quickly and be able to implement restorative actions to prevent issues happening. Confidential reporting is crucial because we're talking about, again, safe environments, psychologically safe environments where people feel confident to report. Because sometimes actually safeguarding concerns are on the back of institutional abuse or neglect, where people perhaps don't realize that they have a duty sometimes to whistleblow. So again, we need whistleblowing policies alongside the safeguarding policies and training. People need to feel safe and be encouraged to report. and then whistleblower if they have concern, because they
Well,
could
this
go
is right.
directly to the Care Quality Commission or the commissioners, whether it's a local authority or whatever other bodies. So again, it's having those systems in place, monitoring that those systems are working, and ensuring that we are up to date all the time.
Yeah, definitely. So thank you for that. So the next one we wanted to look at, and again, it's linked, I think, with some of the other failings we've discussed already, is the poor recruitment practices. We know that recruitment is very challenging, pretty much in any industry, I think. But some of the key failings and takeaways that our team put together were no disclosure and bar in service checks, DBS, for those who will recognize that reference. So basically, those checks are not being done. No reference or interviews. So that process is being fast tracked, probably to meet things like the demand and so on. Visits delayed due to poor rostering. Regulation 19 being breached, so unfit persons employed. And Regulation 18 breached inadequate staffing. Based on things like risk assessments and things like that, not enough staff being rostered or put in place for people's care plans. So again, quite a few different failings there. Some pretty shocking because some of them are a legal requirement. So again, there's some obvious fixes, but what are some of the key fixes people can look at when it comes to recruitment practice for their business?
Yeah, so when you look at the well-led factor here, it's about safer recruitment, not just in policy, but actually in
In
practice.
practice, definitely.
Yeah, making sure that before people come to work, we check their qualifications. We actually check that they have the right to work, but also is the person in front of you the same person whose documents you're holding? There've been issues around that, right?
Yes.
They have the qualifications, they've got references, so they should never start work until they have the two references, right? And interviews and checks and balances, all those are crucial. But also, we need to think about retention as well. When we are recruiting people, we need to think about retention, because also the other issue you raised there was around Regulation 18 breach, where you're talking about inadequate staffing. So sometimes actually the rotas are not managed well. Most of the companies are now using electronic rota systems. So it's about managing them and validating them, ensuring that they're up to date, ensuring that we review our capacity regularly. So some companies take a lot of jobs in.
Yeah.
That's where you end up now with
Sign a
people
lot of
doing 7
contracts.
to 10 minutes per visit, because they've overcommitted. They're trying to sometimes maximize profits, or sometimes it's just poor planning.
Yeah.
Right. So it goes back to actually understanding why we exist at the end of the day. It's to provide excellent care services. Because when you look at any company that's applying to register with the Care Quality Commission, they are promising a lot of things. And I've reviewed, even recently, where you're reviewing documents before people submit them just to support them. And they promise the world. But actually, when it comes to practice, are you going to stick to those
Are you
things?
going to be able to deliver? Yeah.
Exactly.
Yeah. It's
Yeah.
a big challenge.
Mm.
So yeah, recruitment's it is a problem, and cutting corners, as you can see, is probably one of the main problems, particularly for the dom care side of things. But like you say, I think even across the board, in fairness. The next failure we wanted to look at was training and supervision failures. So no training in mental capacity, so MCA, epilepsy, diabetes, or hoist safety. That was one of the key sort of takeaways our team found. No signed off inductions or formal supervisions, and also a breach of Regulation 18, where staff are not appropriately trained or supported. So again, a lot of these themes that we've picked up from the start to where we are now on sort of number 7 they're all interlinked in many ways. What again, without stating the obvious, what are the fixes that providers can put in place here?
Training has to be localized. Right. What do I mean by that? You need to do your organizational needs assessment. And we've talked about this quite a lot. Then you need to do your staff training needs analysis.
Needs analysis, yeah.
Right. Where are your staff right now? What do they need to know? And how best to train them? Right. competency-based induction, right, is really crucial, because you're saying, look, no matter where you have come from, no matter what your background, what your qualifications, if you're going to come in as a care worker, this is the package for care workers working for our company. This is what good looks like in our organization.
Yeah.
Because people bring all sorts of bad habits from wherever they've worked. So you now want to standardize how people work in your organization. That's the only way to improve quality.
Yeah.
You can't improve quality by just ticking boxes to say, yeah, they've done that training. You send them to this company to go and do training. They go and sit there all day and get a certificate.
Yeah.
Then they come and do completely opposite to what your policy is saying.
Change.
What outcomes are you expecting? So it's really crucial. And signing off induction and onboarding, signing off people when they finish their care certificate, supervision. So we're going back again. It goes back to well-led. All these things, actually, organizations that are well-led who have systems in place, right? And reviewing documentation, including CPD trackers, because there's a concept in health and social care of lifelong learning.
Yes.
So whether you're a care worker, you're a nurse, you're a social worker, you're a doctor, a dentist, you have to keep learning because things change.
Yeah.
There's some things that are unsafe to do now, but 20 years ago, they were perfectly acceptable. They were the only way to do things. But 20 years later, things have changed drastically. So if I had kept my knowledge from 20 years ago and do that right now, then I'm providing inadequate service.
Yeah.
Right? It's as simple as that. And we need to link training to the service user needs. And I always say this, because even some of the so-called consultants, they look at us as training providers. And I'm sort of thinking, but what are you doing as a consultant? What, you come and audit some documents and then you list things that they have to do. But actually, when you're a training provider, you should link everything to the outcomes.
Yeah, if you're doing it properly. Yeah.
If you're doing it properly, right? And even if you're training people internally, in-house training, which is, for me, the best form of training. So even if you have external providers, they have to work with your in-house teams to customize that training to some extent for that particular organization, right? But obviously, it's a case of the cost as well.
The cost is always a big factor, yeah.
But also, it's a case of undervaluing training. People worry about what CQC are going to do. Then they want to do some training to tick a box so that they can satisfy CQC. It shouldn't be like that. CQC are coming in to just checking actually that you are meeting the regulations. The forms that you filled in, all the things that you promised, you're doing them. You're actually doing them. Your policies that you built, you're actually applying them. So training has to be linked with policies and procedures and directly related to the actual service user needs. Otherwise, it's pointless.
Yeah.
You can have all the certificates in the world, so many boxes ticked, but then still provide inadequate services.
Yeah. So another theme that our team picked up on was poor care planning and documentation. So some of the common failings in this area were missing health needs, no best interest decisions, and outdated documentation, and also breaches of Regulation 9, where we're looking at person-centered care, and Regulation 17, where we're looking at good governance breaches, which again goes back to the well-led theme we've been discussing a lot today. So, yeah, again, interlinked. Hopefully people are starting to see the connections between the different themes and how they can affect different areas of a domiciliary care business, for example, or the service it's providing. But again, looking at fixes, how do we go about addressing some of these issues in the world we live in now? Like we've said, tech is a lot more accessible. People are using it more in day-to-day life, for example. And I know a lot of people are bringing in tech in this area. But again, if it's not implemented well and you haven't got the right people using it, then it's as good as probably the paper-based records or something like that, yeah.
Yeah, the majority of care companies are now using digital records, digital care planning. But again, we always talk about adoption, isn't it? Say, how do you adopt these technologies? What problems are you intending to solve with these technologies? And what we've seen over and over is not a shortage of technology. It's actually too much technology, which is, we haven't assessed actually fully how we're going to use it, what problems we're going to solve. and we have companies using 5, 6, 7 systems. Sometimes the systems, in most cases, they're not talking to each other. You have to log into different system one step at a time. And sometimes there's duplications. So when you're looking at care planning and documentation, you have to look at the core. What are the people's preferences, right, to start with? Look at their medical history, their social history, their medicines that they have, they're taking, their health needs, and how you are going to support them. But you have to look at the risks as well. So you do your risk assessments. All those things are crucial. And ideally, this information should be in one system. So the problem is, what I've seen over and over again is that managers, care managers, and supervisors are the ones responsible for building those care plans. And then the rest of the staff, they're just filling in daily records. So they sometimes no connection between what people are doing on the floor, on the shop floor, and actually what's in the care plan, because what they're doing is they're just rushing through to get the job done and go to the next job.
Get to the next client, yeah.
Right. So that's a big problem in itself. And also failure to review care plans regularly. Depending on the service, again, there's no hard and fast rule to say, do you review care plans every week, every 2 weeks, every month? You have to have a system based on the needs of the people that you're supporting. And then when those care plans are updated, are you communicating with the people that are delivering care to ensure that they know what the updates are? And also the service user themselves. And when there are incidents, you have to then review everything again and then come up with whatever escalations need to be done or corrections. Care plans, they have to be accessible, they have to be easy to read, and where you need to translate, translations are done by professional people. And visual formats as well are really important. Maybe you're talking about wound care, photographs been taken, if they've been measured, working with district nurses, who else is involved. So multidisciplinary side of things as well. Do we have access to what the district nurse is recommending or the tissue viability nurse is recommending? And including service users in the care planning process and the reviews. Nothing about me without me. So you always have to think about the service user. Quite often the service user is the last consideration. Yeah, and that needs to change.
That mindset. The next one we're going to look at is the language and cultural barriers. We know that the health and social care workforce in the UK is multi-diverse. We know some of the challenges politically with the need for international talent to come to the country to meet the demands. We know about some of the issues with local people in the country that are not necessarily going into this sector, but the demand is increasing. So these sort of issues are probably heightening every year. I think that'd be fair to say. So when you look at some of the failings in this area, it's staff speaking other languages in front of service users, which can obviously cause problems and confusion. Clients left soiled or unsupported. Again, there's various things on that we could tap into. And then more importantly, I suppose, breach of regulation 10, where we're looking at dignity and respect, and also the AIS, the Accessible Information Standard. So, yeah, again, from a fixing side, how do you go about doing this? Because it is quite a challenge, isn't it?
Yes. I mean, English is my second language. And although I grew up speaking English, all my education, English was the mode of instruction. How I use English would be quite different depending on who I'm engaging with.
Yeah.
Some people, I can mix languages and have a perfectly normal conversation. But what won't be acceptable is that the two of us speak a completely different language in front of a service user. And I've told people off before where I remember when I was still working, I was doing some work with a locum agency. And I was one of the nurses. I wasn't in charge of the shift, but I was one of the nurses working on the shop floor. And two healthcare assistants are speaking in their language. And I asked them to stop doing that. And it's a funny story because they were speaking a language that I know.
So you knew what they were talking about.
I knew what they were talking about. So I asked them in English to speak in English. Then they went to the staff room for break. So I went into the staff room I don't know how they didn't pick that. I understood the language. Then they were now talking about me in their language, and I responded in their language.
Oh, that's the best way to shut them up. Yeah.
Yeah, but it goes a long way to say, look, dignity and respect is about because personal care can feel undignified sometimes. I went to hospital 2 years ago to have
Yes.
surgery on my shoulder,
Shoulder injury.
and you're wearing an apron. You're wearing a gown, rather. You're wearing a gown, and it's very undignified. I'm having to use a bottle instead of walking to the toilet because I can't walk to the toilet. I'm having to press the bell. So you don't realize how much that disempowers you.
Yeah, as a human being.
As a human being, you feel, because I'm used to just getting up and doing. Now I need people to help me just put clothes on.
Yeah.
I can't brush my teeth. Try brushing your teeth with the left hand. If you are right-handed, you realize all of a sudden that, God, I can't find my glasses. So all of a sudden you're relying on other people to give you care. And if they leave you exposed, even just for a minute or 5 minutes, it's dehumanizing.
Yeah.
Yeah. So care is very personal, and we need to think about it very carefully. And there are norms as well, cultural norms, religious norms around this. So again, it goes back to that person-centered care, and involving people as well, giving you feedback on how they feel about dignity and respect.
Yeah. What is the service user's expectations?
Exactly, and
Yeah.
their experience. What is their experience of your service?
Yeah.
And then you take
proper
it.
feedback.
Yeah, you take it on board and use it. And language. I mean, we're not talking about say how people speak a language or whether they have an accent or whatever.
No.
It's just about being, communicating to be understood.
Yeah.
Right. And as much as possible, you are speaking a language that the person understands. For example, if I'm giving care to a patient that's struggling with English, but I know their language, that could be an advantage.
Yeah.
I know the language that they're more confident in, but obviously where you need professional translation services, they need to be brought in. But dignity and respect training is crucial. Again, I know it's part of the care certificate, but quite often it's done to tick a box. It's different from what people are doing in practice. And I think we need to use real life examples, give people case studies, and then supervise people and follow up on feedback and complaints and concerns as well.
Yeah, address them head on.
Exactly.
And like you were saying about the culture side, sometimes just doing a course isn't enough. People have different upbringings, different exposures to things. So like you say, that induction, supervision, and like you say, getting feedback, improving the service, I think is all very relevant. So that's quite a challenging one, but hopefully some of those ideas will help from a fixing perspective if you're going through some of those challenges. The last couple I wanted to sort of pick up on, leadership gaps and manager absence. So we're looking at things like provider information return not being submitted, so that's the PIR, no registered manager on site, no audits or follow-up, and also a breach of Regulation 17, where we're looking at poor governance and no leadership oversight again. So again, from a fixing perspective, rather than instead of just some of the obvious things that you could pick up on the failings, how can providers address this?
So it goes back to the basics of governance, right? When you're setting up an organization, what does a well-run organization look like? So we need to define that ourselves. It's in our mission, it's in our vision, it's in our values. But you and I know that those things are written just to look good sometimes.
On paper somewhere, yeah.
Yeah, and even when we talk about manager absence, it doesn't necessarily mean that they are physically absent. Sometimes they are there, but you won't believe that they are there when you look at how the organization is running.
Yeah, you would think there's no manager present, yeah.
Exactly. So it's actually presence and beyond just being on site, actually taking care about things that are happening in the organization. So understanding also that we are accountable for the services. It's a big responsibility to be a registered manager.
Yeah.
Right. It's a huge responsibility. It's not taken lightly, right? And we need to be present in the sense of doing regular checks with people, governance checks, whether it's weekly or monthly, whichever works for our organization. Regular audits as well. So visibility when people know that you're regularly auditing things, you're checking things, and you're also giving them feedback. then there's more responsiveness and collaboration as well. 'Cause some organizations run by fear. They fear the manager, and that's potentially can worsen the
It's
situation.
not the best culture.
Because then culture-wise, then people are always doing things in fear, then they're more prone to making mistakes.
Yeah.
People are penalized unfairly,
Treated differently
treated
and
differently,
so on,
unpaid sick leave or whatever. Some of it is very punitive style of management, actually breaking the law sometimes, with people not understanding basics of employment law. Then things like the provider information return, the PIR, this is a legal requirement. That's how CQC, gather information. It's an online form that you fill in. How CQC gather information shows also from a transparency perspective, you're giving them the information they need for smart regulation. Because then from there they can plan inspections. But obviously, some of these organizations, this is where you get an unplanned, an unannounced inspection, and these organizations are in complete disarray because they are not running according to what they've promised to do. What they tend to do is they think, oh, an inspection is looming. How many times people have come to you and say, oh, we need training or we need this because we think there's an inspection coming. Maybe they submitted a safeguarding notification or something like that. So they know that maybe they're in trouble. But we should never work like that. Those environments need to always be safe for people to do their job without worrying about manager breathing behind their backs.
Yeah.
Right, or cracking the whip.
Yeah.
So some of these things are shocking when I look at some of those examples, and even some of the companies we've worked with before, where you think the culture is just not right, the tension in the organization, even when you're running a basic training course, you can tell that actually people are sitting in groups.
The dynamics,
the politics, and all those sort of things. So leadership scorecards are really important as well. Even in hospitals, I remember when they did a program called the Productive Ward, where they were taking lessons from manufacturing, car industry, lean thinking, and then they'll put the results on the wall to say, well, this is how we're doing, so that everyone passing by, patients, their relatives, everyone can see how many infections we've had. They can see how many delayed discharges, things like that.
Yeah.
Transparency is really crucial.
Yeah.
Then spot checks as well, but you don't do spot checks to scare people. You don't do spot checks to point fingers. It needs to be open and honest, and then people feel they can come forward as well if they have concerns. So even that duty of candor to sort of say, look, when we are asked to provide the information by Care Quality Commission or the commissioners, we're providing that information transparently. We're not hiding information.
Yeah.
Because quite often, it doesn't take much to figure out what's really going on in a business.
Even if things are maybe not what they seem. So another area we've touched on a few times is the underuse of technology, and some of the classic failings that our team spotted were things like the ECM used only for compliance, not insight. We touched on that quite a bit earlier on. Duplicate systems with limited or even sometimes no integration, and also missed opportunities for real-time data that can improve the service. So again, sort of our area here, I'd like to think. What are some of the fixes people can put in place to make the most of the technology out there, or the technology that the business is maybe already paying for?
I think one of the things is always whenever we go to an organization, we always start by reviewing the technology that they have.
Yeah.
And some companies don't like that because they think, oh, you want to do that because you want to charge us to do that. But actually, you could do that yourself to say, look, let's list all the technologies that we have in our care company.
Yeah.
What are we using it for? Then you list the uses. And then very quickly, you can see where the duplications are. What are we gaining from it? What information, actually management information, are we getting from it that we can make better decisions? And where are the duplications? Some systems get out of date, and then very quickly they're overtaken by how you're supposed to be doing things. Do you still need that system? Just because you've paid for it, you don't have to continue using it. But obviously some companies are signing long contracts where 5 years, 7 years. It's shocking actually that some software companies are working like that. But also it's up to you whether you sign a 5-year or 7-year.
You need to know what you're signing as well. Yeah.
Exactly. So in a lot of these systems, we're talking about decision support systems, we're talking about operational systems for medicines management, for core monitoring and things like that. A lot of them have alerts, they have prompts, And actually, there's no point having a system that gives you alerts and then you don't do anything about those alerts. What's the point?
Yeah.
Because if I come in to audit your system or inspect your service, then it shows me that you are not in control.
Yeah. You've got all these things that look fancy, look like they do the job, but in reality, there's a lot of shortcomings. Yeah.
It's because people are not understanding what these systems are doing. They're not understanding the information being provided by the systems. Because even when we build our own software modules, we are always thinking, look, what value is it going to add to an organization? How are registered managers going to be using the system? How is it going to benefit them? Not just to tick a box for compliance, but actually running these organizations efficiently and safely.
And safely.
Right.
Yeah.
So there's a lot that we can talk about, but even data reviews as well. When you have your team meetings, actually, what data is coming out of these systems,
Yeah.
and how is the organization using the data? Because sometimes actually it shows us what's working and what's not working, isn't it? So we can
Yeah.
actually say, look, we've seen a lot of data on this system is saying this, and we're a bit worried. So perhaps we provide a lunch and learn. Oh, maybe we've updated our policy.
Yeah.
There's so much that we can do, and for me, actually, it's going to be a big problem going forward, and it is already a big problem, but it's going to be even worse because of AI and all these systems that are claiming to do so many things that they don't really.
Yeah.
Integration is still another big issue. It's not just in care companies, even in big hospital groups, in NHS trusts, where systems, quite a lot of systems are still not talking to each other. So I know there's the proprietary side where we're saying, look, systems don't want people to know how they've built their system, but actually we need to allow integration. Even for our business, we've open APIs
Yeah.
whereby people, we give them information to be able to integrate with
Yeah.
systems
Push
that
data
are
across
already
systems.
there.
Yeah.
But that's another area where, technology companies, software developers need to work on to integrate systems. Because even for us, if they have a very good system for something that we do, there's no point us trying to push our system. But if they want something from ours, we just push the data to them, or if they push the data to our system,
Exactly,
then
yeah.
they have one dashboard where they can see
Then they get that
all the
operational
information.
efficiency. Yeah.
Exactly.
Yeah.
Yeah.
No, that's I think a really key one, particularly the trends that we're seeing in the market right now. There's a lot of people, even people coming to us right now, that are saying, "I've signed up for this system XXX. I'm tied in for this long, but it's not really working. I've got a system that's meant to be doing this, and it's not." So, yeah, I think there's a duty on the providers to understand what exactly they need, do that necessary analysis of the organization, look at actually the laws they need to meet and the compliance requirements they have in their space or from the local authorities. Technology selection, it almost goes back to the recruitment part we discussed
It's all
earlier.
connected.
Getting that right,
Needs analysis,
yeah,
organizational needs analysis.
get that right technology
Yeah.
in. It's almost, because it can be just as important as the people in the business, depending on what the technology is being adopted for. The next one we wanted to look at was workforce culture failures. Again, another topic we have sort of touched on in an earlier point. So, some of the key failures here were no reflective practice, blame culture, unpaid suspensions, staff fear of whistleblowing, and also breaches of Regulation 18 and 17 again, which fall under this category. So, again, without being too repetitive from earlier, what are some of the fixes that providers could put in place to address some of these failures?
A reflective practice is important for anyone really in health and social care because we learn by doing. And traditionally, it's a sector where it's all about case studies. What cases have you been exposed to? A lot of things that I know about the dangers of certain medications is based on some of the cases that I experienced. A patient coming in with a very low blood pressure or heart rate or whatever the case, then you never forget that. Or sometimes even patients dying, when you do your mortality meetings, big NHS trusts and big hospitals are do mortality meetings where they do root cause analysis to understand, not to blame people, but to actually understand systemically where did we get it wrong? At what point were there clear signs that someone is deteriorating? And you don't have to have fancy support systems, technologies to do these things. It's just about, again, good management systems in place. What does good look like for organizations? So open dialogue, protect whistleblowers, good supervision, and feedback. So staff forums and feedback, give people a voice so that they feel confident to come forward. Even anonymous culture surveys staff culture surveys. The RCN do this culture survey of nurses. How many nurses were off sick for this reason? How many people had back injuries and things? And then people fill these anonymously, but you take them seriously and use them actually to improve
and make change.
And make changes. Yeah.
Yeah, I think culture is always a big one, because we know in this space, particularly post-COVID and even during COVID, there was a lot of media sort of highlight and pressure on people working in the space. And keeping culture, keeping morale high, keeping people focused on what they need to do, but keeping them focused in providing good care. It is a real challenge. And we know some of these providers as well, from a funding perspective, it's not as easy as just saying, let's do a team night out, let's try and do this to improve culture. So some of these things are real challenges, and there are real problems that not even money at times can solve. So I think some of those fixes there can hopefully go a long way into improving culture.
Yeah.
We wanted to now look at some final, almost do a little final summary on some of the points we've touched on in this episode. But in particular, Richard, what is the big message you want every provider to hear?
Yeah. So the biggest problem is we wait for the Care Quality Commission to come, and then they tell us where we are. You shouldn't do that. You should know where your organization is.
Yeah.
So a well-led organization will know where it is, because they are monitoring, they are auditing, they know where they are struggling and what they need to do to improve, and they know where they are doing well generally. So it's involving service users, it's involving staff. And the other issue is around leadership in general, but also looking at how we build our teams. So from safe recruitment policies and practice. Also thinking about retention as part of that initial process, hiring people and how you're going to retain them.
Yeah.
Right. So good induction, real-time oversight, statutory monthly training, refreshers, building a sustainable workforce for your organization is another thing. Then every regulation, when you look at it, that CQC has, goes back to safety, goes back to dignity and respect, goes back to care being person-centered. No matter which setting you're working, whether you're an A&E doctor, you're a GP, a care worker with a small domiciliary care company, it's the same. Of course, your responsibilities will be different, but think about your role in line with the regulations. So people need to understand, when they do statutory monthly training, they're not ticking boxes there, then coming to work here. They need to be able to apply each of those training courses into practice. And then governance being the foundation of every business. And see, when you look at large hospitals, private hospitals, and NHS trusts, they've got clinical governance departments, which are based on a national framework. And for a long time, actually, I know Care England are now doing quite a lot of work in this area with Skills for Care. But for a long time, there's no foundation for governance for care companies. And that needs to change.
Excellent. Okay, so thank you very much for that, Richard. I think hopefully we've give everyone a real insightful discussion today. Like you say, mainly focus on domiciliary care providers, but also actually a lot of these fixes or ideas and suggestions put forward by Richard will be applicable across the board. So thank you very much for joining us, and we will see you next week.